Welcome back to the channel, dear friends. Today's video is about an open globe injury in a 4-year-old child, and this patient presented to me 12 hours after the tip of a pencil went into his eye when he was playing with his brother. So as you can see that there is a full thickness corneal laceration at the 3 o'clock limbus with iris prolapse. Broadly, this injury can be classified as an open globe injury of zone 1 type B, which is penetrating, grade C and pupil negative. If you closely observe the surface of the iris tissue that is prolapsed out of the wound, you'll notice that it is covered by a membranous tissue, and this is the membrane that I'm trying to peel off with this surgical blade. This membranous structure is formed partly from the exudation from the prolapsed iris tissue itself and partly from the migrating epithelial cells that have tried to come and cover this tissue as a healing response. Apart from restoring the anatomical integrity of the globe, we do not want to sacrifice too much of the uveal tissue, and for this reason the uveal tissue has to be prolapsed back into the anterior chamber. If this membranous structure is not completely removed, we are at the risk of two complications in the post-operative period. The first being that any epithelial layer that goes into the anterior chamber is very highly likely to cause a surgical implantation cyst, which can further cause detrimental effect to the visual acuity. And the second thing is that this membranous tissue has acted as a barrier to infection for the last 12 hours. So the surface of this tissue would probably have some form of bacterial contamination because this tissue has been exposed for the last 12 hours. And to prolapse this iris tissue back into the anterior chamber with that intact membranous structure would cause some sort of risk for infection. Once I have freshened the surface of the iris, I now proceed by making a side port incision 90 degrees away from the 3 o'clock limbus, that is at about 12 o'clock limbus. And we proceed with deepening the anterior chamber with 1.4% sodium hyaluronate viscoelastic substance. Next, with a micro forceps, we remove an intraocular cilia which is lying near the wound area. Next, with a 27 gauge cannula, we try to sweep the iris back into the anterior chamber through the wound, being very gentle and not applying too much force for fear of causing an iridodialysis. Once the iris is inside, we further deepen the anterior chamber before proceeding with the first suture, and the first and the most important and the longest suture is always taken at near the limbus. We have to ensure that the first suture bite that we are taking through the limbus is tight enough to cause very good approximation of the wound margins, because this will influence the subsequent sutures and the final post-operative astigmatism. As the plane of anesthesia deepens, you'll notice that the eyeball is rotated superiorly, and it is not a very good idea to take a superior rectus bridal suture in any case of open globe injury. So at this point, I'm trying to reach the superior margin or the superior edge of this wound, and I'm simultaneously asking my anesthetist to slightly lighten the plane of anesthesia so that I can get this second most important suture in. You will observe that this particular suture is pretty small compared to the first cardinal suture that we had given at the limbus, and this is again very important because as the wound is sutured towards the center of the cornea, you want to have smaller bites because again this will influence the post-operative astigmatism. As I attempt to put in my third suture, the plane of anesthesia changes again and the eyeball rotates downwards, and it becomes quite challenging to try and bring the eyeball back to the center. And as you can see now that the eye is rotating towards the inferior fornix, and I have to again ask my anesthetist to slightly deepen the plane so that the eye can be centered once again, because any manual efforts to recenter the eye with tooth forceps were futile because the eye was very tightly rolled downwards. So the third suture has divided the wound into two equal halves, as you can see, and now I plan to put at least one suture on either side to try and fully approximate the wound margins. Once again, I massage the anterior surface of the iris away from the wound margins, ensuring that no strands of the iris are incarcerated. As I've put the 5th suture in, I realized that the very first suture that I had placed at the limbus has now become loose, and I plan to revise this suture. Dear friends, this is a very common phenomena. As you keep suturing the wound and the wound architecture keeps changing, the contour of the cornea keeps changing, some of the sutures will become loose or tight. And we have to absolutely ensure that the loose sutures are revised so that the structural integrity of the globe can be restored and prevention of infection happens. So after inspecting the limbal part of the wound, I decide to expose that area a little more, and I do a localized peritomy at about 3 to 4 o'clock limbus. So I'm now satisfied that there is not much of a scleral extension of this wound, and a single 10-0 nylon suture at the limbus should suffice to approximate this wound, and I wouldn't have to suture the sclera separately. So after burying the last limbal suture, we hydrated the side port and patched the eye under antibiotic ointment and gave some subconjunctival gentamicin and dexamethasone as well. On the first post-operative day, this patient had a vision of counting fingers till 3 meters. The wound was intact. The Seidl's test was negative. Thankfully, there was not too much of a fibrinous reaction. The anterior chamber was relatively quiet, and we hope that this patient has a good outcome in the future. That's all for this video, folks. Thanks for watching.